Welcome to Bookfulness. This is episode 11, the next installment in our deep dive into Moore's clinically oriented anatomy. In the previous episode, we wrapped up our comprehensive discussion of the hand's intrinsic anatomy, focusing on those complex small muscles that grant us such fine motor control.
And now we move proximally to conclude Chapter 3, the upper limb. Our mission today is arguably the most structurally challenging part of the entire limb. We're diving deep into the entire sequence of joints.
Right.
Starting at the root, where the limb meets the axial skeleton, and progressing distally right through to the digits. We'll be covering the final pages of the chapter, that's 491 through 534.
Okay, quite a bit of ground to cover then. Our overall goal is to conduct a really detailed university-level examination of these articulations. We're looking not just at, the names of the structures, but the biomechanics, how these joints actually cooperate to achieve these massive ranges of motion.
Yeah, and where the inherent instability lies too.
Exactly, and crucially, the clinical relevance of that trade-off between, mobility and static stability.
And we absolutely must understand that the design of the upper limb is just. It's a masterclass in compromise, really.
Yeah.
Unlike the lower limb, which, prioritizes stability for weight bearing, the upper limb prioritizes movement. It requires an extremely dynamic system of muscle and ligamentous support to pull that off.
So let's set the stage for that movement. We have to start with its foundation, the pectoral girdle. And what immediately stands out, I think, is that the entire superior appendicular skeleton, so the shoulder blade and the arm, it articulates with the axial skeleton at only one tiny connection.
Exactly. That singular connection is the sternoclavicular joint, the SC joint. This is the only bony bridge between the arm and the trunk. It's incredible when you think about it.
It really is.
The extensive global mobility of the limb hinges entirely on the movement permitted by the clavicle at this joint and, subsequently the free movement of the scapula itself.
So to understand how the limb gets over 180 degrees of elevation, we have to look at how these joints cooperate. We can't just rely on the glenohumeral joint, the main shoulder joint. The key functional concept here is something called scapulohumeral rhythm.
Yes, the rhythm. It's indispensable. As figure 3.9 core C in the text illustrates quite well, full abduction or flexion of the arm just isn't possible without simultaneous movement of the scapula.
Right.
This coordination is typically described as a ratio, roughly. For every 3 degrees of total shoulder elevation, approximately 2 degrees happen at the glenohumeral joint itself.
Okay.
And the remaining 1 degree involves rotation of the scapula on the thorax. And that happens via movement at both the AC and SC joints.
So if you want 180 degrees of abduction, like reaching straight up, 120 degrees come from the shoulder joint itself, but that last 60 degrees must come from the scapular rotation.
Precisely.
And if that rhythm is interrupted, say, due to paralysis of muscles like the serratus anterior or trapezius, which are the big movers of the scapula, the movement just stops prematurely, right? You can't get your arm all the way up.
That's exactly right. That coordinated sequence is why the foundation, that SC joint, absolutely must be robust. So let's delve into the mechanics of that pivotal singular connection, the sternoclavicular joint.
Okay. Anatomically, it's classified as a saddle-type synovial joint, which means the articulating surfaces are reciprocally concave and convex.
Correct. But functionally, because it has such an extensive range of movement, it actually works much more like a ball and socket joint. It permits movement in almost every plane elevation, depression, protraction, retraction, even circumduction.
So it's quite versatile despite the saddle classification.
Very much so. The articulation itself is between the enlarged sternal end of the clavicle and the clavicular notch on the manubrium of the sternum, plus a little bit of the superior part of the first costal cartilage.
Okay.
And a key detail here, something that hints at the forces involved, is that the articulating surfaces are covered by fibrocartilage, not the usual hyaline cartilage.
Fibrocartilage, that usually means high stress, right? Like the meniscus in the knee or the intervertebral discs.
Exactly. This specialized covering is a clear indicator that this joint sustains immense repetitive stress and significant load transmission. It's built tough.
And its structural stability is, well, the book calls it legendary. It's absolutely swaddled in passive restraints, these ligaments.
Indeed it is. The entire articulation, including the epiphysis, the growth end of the clavicle, is encased in a strong joint capsule. But what really provides shock absorption and proves the fit, the congruence, is the presence of a complete, strong articular disc.
An articular disc, okay.
Made of fibrocartilage again. This disc essentially divides the joint cavity into 2 distinct spaces. It acts as a shock absorber, and importantly, it prevents the clavicle from just sliding medially toward the midline relative to the manubrium.
So it keeps things centered and cushioned, and then there are the ligaments providing the static support.
Yes, the shear strength comes from the ligamentous arrangement. You've got the sternoclavicular ligaments, anterior and posterior, which basically just reinforce the capsule itself. But the truly massive restraint, the real powerhouse, is the costoclavicular ligament.
Costoclavicular, so rib to clavicle.
Exactly. This ligament is essential because it's extrinsic to the joint capsule. It's separate. It's a short, incredibly tough band that tethers the inferior surface of the medial end of the clavicle down to the superior surface of the first rib and its costal cartilage.
And its function is?
Its primary function is to resist excessive elevation of the clavicle. It also helps prevent lateral displacement. It's basically what stops the clavicle from popping upwards during extreme shoulder movements.
Makes sense. Now, thinking about movement, the SC joint permits about, 60 degrees of elevation depression?
Roughly, yes, and about 25 to 30 degrees of anterior-posterior movement, which we call protraction, and retraction, think shrugging your shoulders forward and back.
But here's the nuanced detail the textbook highlights, which is crucial for that full 180-degree arc of arm elevation.
Yes, the clavicular rotation.
Exactly. To achieve full elevation, the clavicle has to actually rotate posteriorly, kind of twisting backwards around its long axis, up to about 30 degrees.
That posterior rotation is the mechanical key. It's absolutely vital. If the clavicle didn't rotate like that, it would bump into the first rib and the sternum much earlier, limiting the entire range of arm elevation to maybe, 110 or 120 degrees.
So that little twist unlocks the rest of the movement potential.
It unlocks the necessary scapular movement that contributes to the overall range. It's a beautiful piece of integrated mechanics.
Okay, given all this structural strength, the saddle shape, the disc, the strong capsule, the massive costoclavicular ligament, let's revisit the clinical insight. If this is the only skeletal connection and it's so reinforced, what happens when it does fail? It must take incredible force.
It does. Dislocation of the SC joint is extremely rare precisely because of the strength of those ligaments and the way the articular disc functions. However, in individuals under the age of about 25.
The age factor again?
Yes, the weak link is often not the ligament but the bone itself, specifically the growth plate. The medial epiphyseal plate of the clavicle is actually one of the last in the body to fuse, often not closing until 23 to 25 years of age.
That's quite late.
It is. So significant force, like a direct blow or a fall onto the shoulder in a younger person, often results in a fracture separation through that growth plate. Radiographically, it can look like a dislocation because the main shaft of the clavicle moves, but the little epiphysis piece actually stays attached to the manubrium.
So it mimics a dislocation, but it's technically a fracture through an unfused growth area. That's a crucial distinction for diagnosis and treatment, I imagine.
Absolutely crucial, especially because the management can be quite different.
Okay. Moving laterally along the clavicle then, we find its less stable partner, the acromioclavicular joint, or AC joint.
Right. Structurally, the AC joint is designed for much less movement compared to the SC joint. It's classified as a plane type synovial joint.
Plane joint, so mostly gliding.
Primarily gliding movements, yes. These movements allow the scapula to rotate sort of subtly in relation to the clavicle during that scapulohumeral rhythm we talked about. It also contains an incomplete wedge-shaped articular disc, unlike the complete disc in the SC joint.
And the passive stability here seems, well, deliberately loose almost. The joint capsule is described as thin and sleeve-like.
It is relatively weak. It's only slightly strengthened superiorly by some fibers of the overlying trapezius muscle. The joint itself is inherently not very stable.
But it's saved by something else.
It's saved by a powerhouse structure located entirely outside the joint capsule, the coracoclavicular ligament.
Okay, coracoid process to clavicle.
Exactly. This extrinsic ligament is functionally the most important restraint for the AC joint. It's doing more than just holding the AC joint together. It's essentially anchoring and suspending the weight of the entire scapula and the upper limb from the clavicle.
That sounds critical. Let's break down its two components, because the book notes their distinct geometry is important for how they resist stress. We're looking at figures 3.94 and 3.95 here.
Right. The two parts are the conoid ligament, which is more medial and vertical, and the trapezoid ligament, which is more lateral and runs nearly horizontally.
Okay, conoid first. Vertical.
The conoid ligament is shaped like an inverted cone, with its apex attached down on the coracoid process of the scapula, and its base attaching up to the conoid tubercle on the underside of the clavicle. Because it's oriented vertically, its primary function is to resist vertical displacement. It prevents the clavicle from being driven superiorly, riding up over the acromion.
Got it. And the trapezoid ligament, it's flatter and more horizontal?
Yes, the trapezoid ligament attaches more laterally on the coracoid process and runs superolaterally to the trapezoid line on the clavicle. Being flatter and more horizontal, it primarily resists horizontal forces, particularly the shearing or sliding forces that might try to push the acromion underneath the clavicle.
So they work together to provide multi-directional stability.
Exactly. These two bands are incredibly strong. Sometimes they even have a bursa separating them. They are the definitive measure of stability for the AC joint.
Which brings us to the clinical side. When we hear about an AC joint separation, often called a shoulder separation, which can be confusing.
Yes, it's different from a shoulder dislocation, which involves the glenohumeral joint.
Right, so AC joint separation, figure B3.33 in the text, the injury is graded based on the failure of this specific ligament complex, the coracoclavicular ligament.
Precisely. If the AC joint capsule itself is torn, but the coracoclavicular ligament holds firm, it's usually considered a mild separation, maybe grade 1 or 2. But if the coracoclavicular ligament fails, ruptures completely, then the scapula and the entire arm drop dramatically relative to the clavicle due to gravity. That's a severe separation, often grade 3 or higher, and it frequently requires surgical intervention to restore that crucial connection.
So the integrity of the coracoclavicular ligament is really the dividing line between a minor sprain and a major functionally significant separation.
It absolutely is. And just to round it off, conforming to Hilton's law, the principle that nerve-supplying muscles acting on a joint also supply the joint itself and the skin over it, the AC joint gets its innervation from surrounding nerves, specifically the lateral pectoral nerve, the axillary nerve, and the cutaneous lateral supraclavicular nerves.
A diverse supply reflecting its location.
Yes, its proximity to multiple moving parts and its relatively superficial subcutaneous position.
Okay, we've established the foundation. Now let's transition from the relatively static connections of the pectoral girdle to the main event, the dynamic engine of the limb, the glenohumeral joint. This is where we really maximize mobility, but at a significant cost to stability.
Absolutely. We classify this as the epitome of free movement, a multi-axial ball and socket synovial joint. It allows movement around 3 axes and in pretty much all directions. However, as you said, it is famously the most unstable major joint in the body, and that instability stems primarily from the bony architecture itself.
The analogy often used is quite apt, isn't it? That the articulating surfaces are just a profound mismatch in size.
It's a perfect description. You have the large spheroidal humeral head articulating with the incredibly shallow, almost flat glenoid cavity of the scapula. The glenoid cavity is oriented anterolaterally and slightly superiorly.
And there's an attempt to improve the fit, right? The labrum.
Yes, to try and deepen the socket a bit. The rim of the cavity has a fibrocartilaginous lip called the glenoid labrum. But even with the labrum, the glenoid cavity only covers about a third, maybe even less, of the humeral head's surface area at any given moment.
Just a third. That's tiny. No wonder it's unstable.
Exactly. It relies heavily on other structures.
And that mismatch is reflected in the passive restraints, too. The joint capsule itself is notoriously loose. The text notes it's actually twice the size of the humeral head it contains.
It has to be that lax to permit the massive range of motion we expect from the shoulder. But the consequence is that when your arm is just hanging by your side adducted, the capsule isn't taut. It's redundant, making the joint inherently vulnerable, especially inferiorly.
Are there any ligamentous thickenings within the capsule that try to help?
There are. Anteriorly, we have the 3 relatively weak glenohumeral ligaments, superior, middle, and inferior. They provide some anterior stability, particularly the inferior one when the arm is abducted and externally rotated. Superiorly, the corticohumeral ligament runs from the coracoid process to the greater tubercle of the humerus. It strengthens the top part of the capsule and provides crucial support against gravity, especially when the arm is deducted, helping to hold the weight of the arm up.
And there's one more ligament mentioned related to a major arm muscle tendon.
Ah, yes, the transverse humeral ligament. Now, this one doesn't directly stabilize the articulation between the humerus and glenoid. Instead, it's structurally important because it bridges the gap between the greater and lesser tubercles of the humerus.
Over the bicipital groove.
Precisely. It transforms the intertubercular sulcus, or bicipital groove, into a canal. And this canal effectively holds down and secures the long head of the biceps brachii tendon as it passes through the groove and into the joint.
So it keeps the biceps tendon in place during movement. Okay. Now, there's a structure often overlooked when just thinking about the joint surfaces, but it's critical. The protective shield above the joint, the coracoacromial arch, that's figures 3.96 and 3.97.
Yes, this arch is formed by the acromion process posteriorly, the coracoid process anteriorly, and the strong coracoacromial ligament spanning between them. It sits superiorly, creating this rigid protective roof made of bone and ligament right over the humeral head.
And its function is mainly protective.
Primarily, it prevents the humeral head from being driven superiorly, especially during activities like falling on your outstretched hand or even just pushing down hard on a desk. Any force that tries to compress the joint upwards meets this rigid arch.
It sounds like an excellent protective measure structurally, but knowing anatomy, rigid structures next to moving parts often mean friction and potential problems. Is this arch also the source of some common shoulder issues?
You've hit on the dynamic trade-off perfectly. While protective, this rigid arch is indeed the site of the joint's most common chronic pathology, impingement syndrome. Because the roof is rigid, something underneath it, passing through that narrow space, is going to experience friction and compression during movement.
And what structures are in that subacromial space?
Primarily the tendon of the supraspinatus muscle, the long head of the biceps tendon, and the subacromial bursa.
Which leads us to the real stability providers for the glenohumeral joint. It's not the loose capsule or the weak ligaments, but the dynamic support from the muscles that essentially wrap around the joint.
Exactly, the rotator cuff muscles.
Let's quickly reiterate the SITES muscles: supraspinatus, infraspinatus, teres minor, and subscapularis. Their function is often thought of simply as rotation, but their most critical role is actually dynamic joint compression, isn't it?
Absolutely. Their tendons blend intimately with the fibrous layer of the joint capsule itself. They form this muscular cuff anteriorly the subscapularis, superiorly the supraspinatus, and posteriorly the infraspinatus and teres minor. There's a gap inferiorly, which is why dislocations are often antero-inferior. Their combined constant low-level or tonic contraction generates a significant compressive force. They act like a dynamic vice grip, actively pulling the large humeral head medially into the smaller, shallower glenoid cavity. They center the ball in the socket.
And this compression maintains the joint's center of rotation, the fulcrum, allowing for that huge range of movements we see in figure 3.98. Flexion, extension, abduction, adduction, medial and lateral rotation, and circumduction.
And we really need to dive into the specific mechanics of abduction, getting the arm away from the side, because this is such a frequent source of clinical problems. We know the powerful deltoid muscle is the prime mover for abduction.
Right, the big shoulder cap muscle.
But biomechanically, it's actually insufficient to start the movement from a fully adducted position.
Why is that? Why do we need the supraspinatus, one of the smaller rotator cuff muscles, to initiate abduction? Just getting the arm up for maybe the first 15 degrees or so?
It's about the line of pull. At the very start of abduction, when your arm is hanging straight down at 0 degrees, the line of pull of the deltoid muscle is almost vertically superior. It's nearly parallel to the surface of the glenoid cavity.
Okay.
So if the deltoid contracted alone at that point, it wouldn't effectively rotate the arm outwards. Instead, it would mostly just pull the humeral head straight up, superiorly, jamming it against that rigid coracoacromial arch we just talked about.
Causing impingement right away.
Exactly. The supraspinatus, however, has a more favorable line of pull at the start. It pulls slightly superiorly, but also significantly laterally. So it initiates the abduction movement, the outward rotation, and crucially, it also helps to compress the humeral head down slightly into the glenoid, counteracting the upward pull of the deltoid as it kicks in. It basically sets the stage for the deltoid to take over effectively after about 15 degrees.
That's fascinating. It highlights the dual role the textbook mentions for the rotator cuff muscles. They act as both tensors and shunt muscles.
Precisely. As tensors, their continuous low-level background contraction keeps the joint surfaces approximated, maintaining joint integrity even when you're just standing there at rest.
And as shunt muscles,
they actively resist translational forces, essentially preventing dislocation. This is absolutely critical when the arm is loaded, like when you're carrying something heavy, a suitcase, a bucket of water. Gravity is constantly trying to pull the humeral head inferiorly, straight down out of the shallow socket.
Right.
The rotator cuff muscles, especially the supraspinatus, along with the long heads of the triceps and biceps, which also cross the joint, provide the active stabilizing force that resists this downward pull and prevents the arm from essentially being pulled out of its socket.
Okay. Now, to protect those actively working tendons, especially the supraspinatus passing under that bony roof, the joint relies on key lubricating systems, the bursa.
Yes. Bursae are fluid-filled sacs designed to reduce friction between moving parts. The primary protective mechanism here is the subacromial bursa. It's often described as being contiguous with the subdeltoid bursa, forming a large cushion.
And its function is purely friction reduction.
Primarily, yes. It facilitates smooth gliding. As the supraspinatus tendon passes directly underneath the coracoacromial arch during arm elevation, this bursa acts as a fluid-filled cushion, shielding the tendon from the potentially rough friction generated by that rigid bony roof above it. There's also a subtendinous bursa of subscapularis between the subscapularis tendon and the neck of the scapula.
That friction, or the failure of smooth gliding, brings us directly into clinical pathology. Rotator cuff injuries are incredibly common, perhaps the most common cause of shoulder pain, right? Figure B3.34 shows this.
Absolutely. The sheer volume of use throughout life, combined with those tight mechanical constraints of the subacromial space, makes the rotator cuff tendons highly vulnerable, and the supraspinatus tendon is overwhelmingly the most commonly affected structure.
Is it usually an acute tear, like from a fall?
Sometimes, but often it's not an acute tear. It's more frequently chronic degeneration. We call it tendinosis or tendinopathy, rather than just tendinitis resulting from repetitive microtrauma and attrition. The tendon gets repeatedly squeezed or impinged between the humeral head and the acromion during elevation activities over many years. This is why it becomes so much more common in individuals aged 50 and older. It's a wear and tear phenomenon.
And the result of this attrition, this impingement, is the classic symptom known as the painful arc syndrome. We need to be really specific about why the pain typically occurs only within a specific range of motion, usually cited as between 50 and 130 degrees of abduction.
Yes, it's a very precise biomechanical trap. When your arm is below about 50 degrees of abduction, the supraspinatus tendon and the subacromial bursa are not yet significantly compressed against the inferior surface of the acromion or the coracoacromial ligament. There's usually enough clearance in the subacromial space.
Okay, so no pain initially.
Right. But as the arm elevates past 50 degrees, the greater tuberosity of the humerus, where the supraspinatus attaches, starts to pass under the acromion, and the tendon and bursa begin to get squeezed or impinged against the arch. This causes pain.
And this persists through the mid-range.
Yes, this impingement continues throughout the mid-range of movement up until approximately 130 degrees. Then something interesting happens. Once the arm gets above 130 degrees, the scapulohumeral rhythm kicks in significantly. The scapula rotates upward sufficiently, which effectively lifts the acromion up and slightly out of the way. This relieves the compression on the tendon and bursa, allowing for pain-free movement again up to full elevation.
So the pain exists only during that specific arc where the structures are being mechanically compressed. Makes sense.
Exactly. It's a very characteristic finding.
Now, if chronic attrition and impingement are one side of the clinical coin, acute trauma leads to the other major shoulder problem. Anterior dislocation of the glenohumeral joint, shown in figures B3.35 and B3.36. The text says this is the most common major joint dislocation in the body.
It is indeed. And the mechanism of injury is quite typical, especially in younger adults and athletes. It usually involves a forceful blow or fall onto an arm that's in a particularly vulnerable position. Usually excessive extension combined with forceful lateral or external rotation and abduction.
Like a quarterback throwing a pass and getting hit, or falling backwards onto an outstretched hand.
Precisely those kinds of mechanisms. This leverage drives the humeral head forcefully in an inferior-anterior direction. Remember, we said the rotator cuff reinforcement is weakest inferiorly?
Right, there's a gap there.
So the head tears through the anterior and inferior parts of the joint capsule. Often, it also strips the glenoid labrum away from the anterior rim of the glenoid cavity. This is called a Bankart lesion, a very common accompanying injury that contributes to recurrent instability later on.
Okay, so the head pops out infero-anteriorly. Once it's out of the socket, where does it usually end up? And what's the really serious neurovascular risk associated with this specific type of displacement?
Once the head is out, the powerful muscles of the chest and back, like pectoralis major, latissimus dorsi, tend to immediately pull the now loose humeral head superiorly and medially from its initial inferior-anterior position. It typically comes to rest in what's called a subcoracoid position, just beneath the coracoid process. You can often feel the humeral head there anteriorly.
Okay. And the nerve risk?
The critical risk here is to the axillary nerve, because the axillary nerve winds quite tightly around the surgical neck of the humerus just below the head. The forceful inferior-anterior displacement and then the subsequent positioning of the head in that subcoracoid location places the nerve under severe traction or potential compression. This can lead to damage, resulting in paralysis of the deltoid muscle, causing inability to abduct the arm, and the teres minor muscle, as well as sensory loss over the lateral aspect of the shoulder, the area sometimes called the regimental badge area. Checking axillary nerve function is absolutely critical after a shoulder dislocation.
Wow. Okay, a lot going on at the shoulder. Let's move distally now. We leave the complex instability of the shoulder and transition to the dedicated stability of the elbow. If the shoulder is designed for range, the elbow seems designed to act more like a strong, simple strut.
That's a great way to put it. The elbow joint is classified as a classic hinge-type synovial joint. Its primary function is really just movement in one plane, flexion and extension, bending and straightening.
Structurally, it's actually a bit complex, though, isn't it? It involves more than just two bones meeting.
It does. It's a compound articulation. It combines the humeral-ulnar joint, where the trochlea of the humerus, which looks like a spool, articulates with the deeply curved trochlear notch of the ulna.
That provides the main hinge action.
Yes, that's the primary articulation responsible for the hinge movement. And then you also have the humeradial articulation, where the rounded capitulum of the humerus articulates with the slightly concave superior surface of the head of the radius.
Does the radius contribute much to the hinging?
It contributes, gliding along with the ulna during flexion and extension, but its main role at the elbow complex is actually in rotation, pronation, and supination, which we'll get to with the radio-ulnar joints.
Okay, so unlike the shoulder's shallow socket, the bony fit here at the elbow, particularly between the trochlea and trochlear notch, is exceptionally tight and congruent.
It really is. That deep socket of the trochlear notch gripping the trochlea provides tremendous inherent bony stability. The elbow relies much less on dynamic muscular support for its basic integrity compared to the shoulder. However, the passive stability is still significantly reinforced by massive ligaments on either side.
Right, the collateral ligaments.
Yes, the joint capsule itself is reasonably strong, but the real integrity against sideways forces hinges on the powerful collateral ligaments that rigidly bracket the joint medially and laterally. That's shown well in Figure 3.1.
Let's start medially. That's the medial ulnar collateral ligament, or UCL. This one gets a lot of attention in sports, especially baseball.
It does, because it resists valgus stress forces trying to push the forearm outwards relative to the humerus, which happens during the throwing motion. The UCL is exceptionally robust.
What are its key components?
It's generally described as having three parts. The most important is the strong, cord-like anterior band. This is the primary restraint against valgus stress, especially when the elbow is extended or slightly flexed, and it's the part most critical for throwing athletes.
That's the one reconstructed in Tommy John surgery.
Exactly. Then there's also a weaker, fan-like posterior band, which becomes more taut during deep flexion, and some oblique fibers that run transversely, essentially deepening the socket for the trochlea. But the anterior band is the main player clinically.
Okay. And then on the lateral side, the situation is a bit different because the radius needs to rotate, right? So the ligament can't just lock everything down.
Precisely. The lateral restraint is the lateral radial collateral ligament, or RCL. This ligament is more fan-like and originates from the lateral epicondyle of the humerus. But crucially, it doesn't attach primarily directly to the radius itself, because that would block rotation.
So where does it attach?
Instead, its fibers blend seamlessly with and insert onto the annular ligament that encircles the head of the radius.
Ah, the annular ligament, which holds the radial head in place for rotation. We'll come back to that.
Yes. So this arrangement is quite clever. The RCL stabilizes the entire humeral-ulnar hinge joint against varus stress, inward force, while simultaneously allowing and accommodating the necessary rotation of the radial head during pronation and supination.
Clever design. Now, beyond simple flexion and extension, the elbow complex is famous for creating something called the carrying angle. Figure 3.101 illustrates this. Can you explain how this slight angle actually helps us function?
The carrying angle is the slight outward deviation, technically a valgus angle, meaning the forearm angles laterally, away from the midline of the body, when the elbow is fully extended and the palm is facing forward, supinated.
Okay.
It typically measures somewhere between 10 to 15 degrees. And it's often noted to be slightly greater in females, possibly due to wider pelvic structure. The biomechanical purpose is quite simple and elegant, really.
How so?
When you're walking and carrying objects like a bucket or a suitcase, this angle ensures that the forearm and the object you're carrying clear your hip and thigh. It allows your arm to swing freely during gait without constantly bumping into your leg.
Ah, makes sense.
And interestingly, when you flex your elbow, the carrying angle largely disappears, allowing your hand to move more directly towards your face and mouth for activities like eating.
Convenient. Okay, considering the bony prominences around the elbows, lower the pointy bit at the back, the olecranon, it seems like it would be prone to bursitis, like we saw at the shoulder.
Very much so. The olecranon process of the ulna is highly subcutaneous, meaning it's right under the skin with very little soft tissue padding. This makes it extremely vulnerable to repetitive friction, pressure, or direct trauma.
And there are specific bursae there. Figure 3.103 shows them.
Yes, there are typically 3 olecranon bursae described: intratendinous within the triceps tendon, subtendinous between the triceps tendon and the olecranon, and the most clinically relevant one, the subcutaneous olecranon bursa. This one lies right between the skin and the olecranon process.
And that's the one that gets inflamed.
That's the one that commonly gets inflamed due to repetitive pressure or trauma, historically associated with students leaning on desks, student's elbow, or bakers leaning on counters, baker's elbow, or just from a direct fall onto the point of the elbow. This causes painful inflammation and often significant swelling, sometimes looking like a golf ball under the skin at the back of the elbow. It's called olecranon bursitis.
Right, I can picture that. Turning to more acute trauma patterns, let's analyze the fracture of the olecranon, shown in figure B3.21. What makes this a particularly problematic type of fracture?
It's often an avulsion fracture, meaning a piece of bone is pulled off by a tendon or ligament. While direct falls onto the elbow can certainly cause a fracture, the classic mechanism involves a fall onto an outstretched hand combined with a sudden, forceful reflex contraction of the powerful triceps brachii muscle.
Because the triceps attaches right onto the olecranon.
Exactly. The triceps tendon inserts directly onto the olecranon process. So that intense tonic pull of the muscle trying to straighten the elbow during the fall often just pulls the bony fragment of the olecranon away from the main shaft of the ulna.
And why is that particularly problematic for healing?
Because the triceps muscle is always under some tension, its pull constantly distracts or pulls apart the fracture fragments. It prevents them from staying aligned. Because of this distraction force, this type of fracture nearly always requires surgical intervention, usually internal fixation with pins, wires, tension band wiring, or a plate to pull the fragments back together and hold them securely against the constant pull of the triceps while the bone heals.
Okay, so the muscle pull necessitates surgery. Now, another specific trauma pattern mentioned is seen primarily in children. Avulsion of the medial epicondyle, figure B3.38 in the clinical box, though the main text mentions it too. This ties back to that concept of late epiphyseal fusion again, doesn't it?
It absolutely does.
Yeah.
This is a critical pediatric elbow injury to recognize. The ossification center, or epiphysis, for the medial epicondyle of the humerus is one of the last around the elbow to fuse to the main shaft of the humerus. Fusion might not complete until the late teens, potentially up to age 20.
So it's a weak spot for a long time.
It is. Now, if a child experiences a significant valgus force on their elbow, meaning the forearm is forced outwards, like in a fall onto an outstretched hand or a forceful twisting injury, maybe in sports, this transmits extreme tension to the structures attached to that medial epicondyle.
And what attaches there?
2 main things.
Yeah.
The strong ulnar collateral ligament, UCL, and the common tendon for the forearm flexor and pronator muscles, the common flexor origin.
Okay.
In an adult, this valgus force might tear the UCL. But in a child or adolescent with an unfused epichyphysis, the bone itself is weaker than the ligament. So the traction force often pulls the entire bony epiphysis of the medial epicondyle clean away from the humerus rather than tearing the ligament.
An avulsion of the whole growth center.
Exactly. And this can sometimes be complicated if the avulsed fragment gets displaced and pulled into the elbow joint space itself, which can block movement and requires urgent attention.
Right. Important distinction between adult and pediatric injuries there. Okay, let's move on to the mechanics of the forearm itself. The true magic of the upper limb's versatility, allowing us to turn our palm up and down, comes from the articulation between the radius and ulna.
Yes, this involves 2 distinct but kinematically linked articulations. The proximal and distal radio-ulnar joints. Let's start proximally. The proximal radio-ulnar joint is classified as a pivot joint.
Pivot, okay.
Here, the head of the radius, which is disc-shaped, rotates within a fibro-osseous ring. This ring is formed partly by the radial notch on the lateral side of the ulna and completed by the crucial annular ligament. Figures 3.104 and 3.105 show this beautifully.
The annular ligament It acts like a circular collar or sling around the radial head.
That's a perfect description. It wraps around the head and neck of the radius, holding it firmly against the side of the ulna. But it's lined with synovial membrane, allowing the radial head to spin smoothly within it during pronation and supination, while maintaining stability.
And this joint shares the same capsule as the main elbow joint.
Yes, the entire proximal radio-ulnar articulation is contained within the capsule of the main humeral-ulnar and humeradial joints, allowing for coordinated movement. And it's this structure, the annular ligament holding the relatively small radial head, that's implicated in that common childhood injury, pulled elbow, which we'll definitely review in the clinical synthesis.
Okay, so that's proximal. Distally, near the wrist, we have the distal radio-ulnar joint. Is that also a pivot joint?
Yes, it's also classified as a pivot joint. Here, the rounded head of the ulnar articulates with the ulnar notch on the medial side of the distal radius. However, the structure of this joint is fundamentally defined by a key piece of cartilage that manages the slight incongruity between the two bones and also interfaces with the wrist complex.
Ah, you must be talking about the TFCC.
Exactly. The triangular fibrocartilaginous articular disc, often called the TFCC, or triangular fibrocartilage complex, figures 3.106, 3.1007. This disc is paramount down here.
What does it do?
It has several critical functions. First, it binds the distal ends of the radius and ulna together, providing stability to the distal radio-ulnar joint. Second, it separates the synovial cavity of the distal radio-ulnar joint from the cavity of the radiocarpal main wrist joint just below it. And third, functionally, it acts as the primary articulating surface between the head of the ulna and the carpal bones, specifically the triquetrum. It cushions and transmits load from the ulnar side of the wrist.
So it stabilizes, separates, and articulates sessions. Very important structure.
Absolutely. Tears of the TFCC are a common cause of ulnar-sided wrist pain.
Okay, so when we combine the actions of the proximal and distal radio-ulnar joints, we get the composite movement of pronation, turning the palm down or posteriorly, and supination, turning the palm up or anteriorly. Figure 3.108 shows this. Let's hammer home the crucial kinematic principle here because it's often counterintuitive for students. What bone actually moves?
This is key. The fundamental detail is that, particularly when the elbow is flexed to prevent shoulder rotation from confusing things, the ulna remains relatively fixed. It's the stable axis. It's the radius that pivots or rotates around the ulna.
Okay, the radius moves, the ulna stays put.
Largely, yes. During pronation, the distal end of the radius swings medially, crossing anteriorly over the ulna. This is why the radial head is proximal near the elbow, and the ulnar head is distal near the wrist. The radius has to cross over. During supination, the radius swings back laterally, uncrossing itself, so the two bones lie parallel again.
And this crossover mechanism allows for quite a large range of rotation.
It does. This elegant mechanism allows the hand to rotate through about 150 to 180 degrees, which is essential for countless daily tasks. And notice again, the ulna contributes very little to the actual wrist joint movement because of that TFCC articular disc. This allows the ulna to serve effectively as the stable post or axis for the radius to rotate around.
Brilliant design. Okay, the forearm provides that rotational freedom, and all that energy and movement is then transferred to the hand via the wrist complex. The wrist has a tough job. It needs to provide extensive biaxial movement, but also serve as a stable base for the fine, intricate movements of the fingers and thumb.
Exactly. The primary articulation here is the wrist joint proper, technically called the radiocarpal joint. It's classified as a condyloid or ellipsoidal type synovial joint.
Condyloid, so movement in two planes.
Yes, it allows movement predominantly in two perpendicular planes, flexion, bending forward, and extension, bending backward, and also radial deviation, abduction tilting towards the thumb side, and ulnar deviation, adduction tilting towards the little finger side. Circumduction is possible as a combination of these.
And looking at the articulating surfaces, figures 3.109, 3.110, this reinforces the kinematic division we just discussed in the forearm, doesn't it? The ulna seems completely excluded from this main wrist joint cavity.
That's exactly right, thanks to that TFCC articular disc we just discussed. The joint space is formed proximally, primarily by the concave distal articular surface of the radius, and medially by the inferior surface of that triangular articular disc, TFCC.
Okay, so radius and disc form the socket.
Yes. And distally, this socket articulates with the convex surfaces of the first or proximal row of carpal bones specifically, the scaphoid, the lunate, and the triquetrum. The pisiform doesn't really participate in this joint.
And because the radius takes the lion's share of this articulation, does that mean most of the force transmitted from the hand up the forearm goes through the radius?
Yes, it does. The majority of axial load transmitted from the hand during activities like pushing up from a chair or falling on an outstretched hand passes through the scaphoid and lunate to the radius.
Yeah.
This is reflected clinically in the high frequency of distal radius fractures, like Colles fractures.
Makes sense. Okay, let's look at the range of motion available at the wrist, shown in figure 3.101. How much total movement do we get here, and is all happening just at this radiocarpal joint?
The radiocarpal joint is definitely responsible for most of the overall wrist movement, particularly flexion and radio-ulnar deviation. However, the textbook clearly states, and this is important, that achieving the full range, especially of flexion and extension, requires the coordinated action of the joint just distal to it, the midcarpal joint.
The midcarpal joint, that's one of the intercarpal joints between the two rows of carpal bones.
Exactly. For example, wrist extension is typically around 70 to 80 degrees. While the radiocarpal joint contributes a significant chunk of that, the midcarpal joint provides the crucial final degrees needed to reach maximal extension. Similarly for flexion, they work together synergistically.
And the movements are asymmetric too, aren't they? You can tilt your wrist towards the little finger side, ulnar deviation, much more than towards the thumb side, radial deviation.
That's right. That asymmetry, typically around 40 degrees, maybe even more, of ulnar deviation versus only about 15 degrees of radial deviation, is a direct consequence of the bony anatomy. The styloid process of the radius projects further distally than the ulnar styloid process. This long radial styloid physically blocks or restricts excessive radial deviation, while the shorter ulnar styloid process allows for a much greater range of ulnar movement.
Simple mechanics. Functionally, the position of the wrist is absolutely foundational for grip strength, isn't it? You have to hold your wrist in a specific position to maximize the power of your hand and fingers.
Absolutely critical. The position of mild extension, often cited as around 20 or 30 degrees of wrist extension, is identified as the most stable and functionally optimal position for grip. It's often called the functional position or resting position of the wrist.
And why is that specific position so important?
It's primarily due to a biomechanical principle involving the length-tension relationship of the extrinsic finger muscles, sometimes related to the concept of the tenodesis effect. When the wrist is extended, the long finger flexor tendons that pass over the wrist are put under optimal stretch or tension. This ensures that when the flexor muscles contract, they can generate their maximal force for gripping.
So extending the wrist optimizes the finger flexors. What happens if you try to grip hard with your wrist fully flexed?
If you hold your wrist in full flexion, those same finger flexor muscles become slackened. They're shortened to a state called active insufficiency. They can't generate nearly as much force. As a result, your grip strength plummets dramatically, sometimes by 50% or even more. Try it yourself. Make a tight fist with your wrist straight or slightly extended, then try to make the same fist with your wrist fully bent down. You'll feel a huge difference in power.
Yeah, you really do. Okay, so managing this complex articulation requires incredibly fine-tuned control and sensory feedback, which must be reflected in its nerve supply.
For sure. The innervation follows a broad application of Hilton's law, reflecting the numerous muscles that cross the joint and the need for precise proprioception. The wrist joint is supplied by articular branches from the anterior interosseous nerve, which is a branch of the median nerve, the posterior interosseous nerve, the continuation of the deep branch of the radial nerve, and also the dorsal and deep branches of the ulnar nerve.
So contributions from all three major forearm nerves, median, radial, and ulnar.
Yes, this diverse innervation ensures high levels of proprioception, the sense of joint position and movement, which is absolutely essential for placing the hand accurately in three-dimensional space and for finally controlling grip forces.
Okay. Deep to the main radiocarpal joint are the other joints within the carpus itself, the intercarpal IC joints.
Right. These are largely defined as plane-type synovial joints. They exist between the individual bones within each row, proximal row and distal row, and importantly, between the two rows themselves.
And their main function is just gliding.
Primarily, yes, they permit small gliding and sliding movements between the carpal bones. This allows the carpus as a whole to adapt subtly to the shape of objects being gripped and contributes to the overall flexibility of the wrist complex. The most significant of these is the midcarpal joint, which is the articulation between the proximal row, scaphoid lunate tricutrum, and the distal row, trapezium, trapezoid, capitate, hamate.
And as you mentioned, the midcarpal joint acts synergistically with the radiocarpal joint.
Yes, it contributes significantly to the total range of wrist flexion and extension, especially helping achieve the extremes of those movements. Its innervation is generally consistent with the adjacent wrist joint, supplied by branches of the anterior interosseous, median, and the dorsal and deep branches of the ulnar nerve.
Okay, we've made it through the wrist. We have finally arrived at the terminal joints of the upper limb, those within the hand itself. This is the ultimate expression of precision movement, all built on the foundation of stability we've just discussed proximally.
We begin with the transitions from the carpus out to the metacarpals, the carpometacarpal, CMC joints, and also the intermetacarpal IM joints between the bases of the metacarpals. For fingers 2 through 5, index the little finger, the CMC and IM joints are relatively simple, plain synovial joints.
Plain joints again, so just a bit of gliding.
Exactly. They allow for a small degree of gliding movement between the distal carpal row and the metacarpal bases, and between the metacarpal bases themselves. This subtle movement is actually quite important because it enables the cupping, hollowing, and flattening of the palm, which is necessary for conforming the hand to grip objects of different shapes and sizes. There's more mobility at the 4th and 5th CMC joints, which helps with making a tight fist.
But the articulation for the thumb, that's the game changer, isn't it? The defining structural difference that gives humans such dexterity.
Absolutely. The CMC joint of the thumb, the first CMC joint, between the trapezium carpal bone and the base of the first metacarpal, is completely different. It's a highly specialized and incredibly mobile saddle joint. Figure 3.112a shows its shape.
Saddle joint, like the SC joint way back at the beginning, but maybe even more specialized.
Arguably, yes, in terms of functional importance for the hand. This unique geometry where each articular surface is concave in one direction and convex in the perpendicular direction, fitting together like a rider sitting in a saddle, allows the thumb metacarpal to move freely in two principal planes relative to the trapezium: flexion-extension across the palm and abduction-adduction away from towards the palm.
And crucially, it allows for opposition.
That's the most important consequence. Opposition is that complex, unique movement combining flexion, abduction, and a degree of medial rotation of the first metacarpal that brings the pad of the thumb across the palm to meet the pads of the other fingers. This is the movement that makes human grasping, pinching, and fine tool manipulation possible. It all hinges on the saddle shape of that first CMC joint.
Incredible joint. Okay, moving distally from the metacarpals into the digits proper, we encounter the joints of the fingers themselves. First are the metacarpophalangeal, MP, joints, the large knuckles at the base of the fingers. What type are they?
The MP joints, of fingers 2 to 5, are classified as condyloid joints, similar to the radiocarpal joint.
Condyloid again, so biaxial movement.
Yes. As condyloid joints, they permit flexion and extension, bending and straightening the finger at the knuckle, but also abduction, spreading the fingers apart, and adduction, bringing them back together. Circumduction is also possible here. In fact, the MP joints are the most distal joints in the upper limb that normally permit abduction and adduction, allowing you to splay your fingers.
Now, the stability of the MP joints has an interesting feature related to their collateral ligaments, shown in figures 3.112b and c. They behave differently depending on whether the joint is flexed or extended.
Yes, this is a crucial biomechanical adaptation. The strong collateral ligaments on each side of the MP joints are functionally quite taut or tight when the joint is fully flexed, like when making a fist. However, they become relatively lax or loose when the MP joint is extended, when the finger is straight.
And what's the functional significance of that?
It's perfectly suited for hand function. Since gripping and forceful activities nearly always involve flexing the MP joints, the ligaments need to be taut in flexion to provide maximum lateral stability to the joint when the hand is applying force or holding an object tightly. Conversely, the relative laxity of the ligaments in extension allows for the abduction and adduction movements, the spreading and closing of the fingers, which is necessary when the hand is open, like when reaching to grasp something.
So stability when needed for power, mobility when needed for positioning. Very clever.
Yes.
Okay, finally, the last joints in the chain. The joints within the fingers themselves, the interphalangeal IP joints, we have proximal ones, PIPs, and distal ones, DIPs, in fingers 2 to 5, and just one IP joint in the thumb. What type do these revert to?
These revert to the simplest structure for directional control. They are purely hinge joints.
Hinge joints.
Yeah.
So only one axis of movement.
Exactly. They permit only uniaxial movement, flexion and extension, bending and straightening the finger segments. Their joint capsules and very strong collateral ligaments ensure high stability and prevent virtually any significant lateral side-to-side, or rotational movement. This guarantees that the terminal motion of the fingers is simply opening and closing the grip with precision.
Okay, we've completed the anatomical journey joint by joint from the trunk to the fingertips. Now let's use the final clinical review section in the book, pages 521, 534, not just to repeat the pathologies we touched on, but maybe to synthesize the patterns of trauma across the entire upper limb, highlighting how the vulnerability shifts, often depending on age or the specific mechanism.
That sounds like a good way to integrate it all. Let's start proximally again at the pectoral girdle and focus on that concept of the weakest link in the chain. At the SC joint, related to figure B 3.33, we saw a clear contrast. The joint itself is structurally almost inviolable. Its ligaments, especially the costoclavicular, are often stronger than the young bone.
Right. So in youth, the pathology defaults to a fracture separation of the epiphysis rather than a true ligamentous dislocation.
Precisely. But conversely, just laterally at the AC joint, the joint capsule itself is inherently weak.
Yep.
Its stability relies almost entirely on that extrinsic coraconclavicular ligament.
So if that ligament complex fails under significant force,
You get a significant AC dislocation or separation, where the scapula and arm drop because the primary suspension system is compromised. So the difference in injury pattern between an AC separation and an SC injury often comes down to which specific structure the joint's own ligaments, AC, the extrinsic suspension system coraconclavicular, or the late-fusing growth plate, SC, absorbs and fails under the traumatic energy first.
Okay. Moving to the shoulder, the glenohumeral joint, the pattern shifts away from simple passive restraint failure towards issues with the dynamic system or catastrophic failure due to inherent instability.
Exactly. Rotator cuff injuries, figure B 3.34, typically represent a chronic wear and tear failure, an attrition of the dynamic stabilization system, particularly the supraspinatus tendon. This leads to chronic impingement, which clinically manifests as that characteristic painful arc syndrome during abduction, specifically between roughly 50 and 130 degrees.
And the acute injury.
Acute glenohumeral dislocation, figure B 3.35, most commonly anterior or infero-anterior, represents a catastrophic failure of the inherently unstable joint, usually tearing the anterior capsule and often the labrum. And the key associated risk here, due to the direction of displacement, is injury to the axillary nerve as it wraps around the surgical neck.
Down at the elbow, the inherent rigidity seems to create its own unique vulnerabilities. We noted the risk of elbow joint dislocation, figure B 3.40, which is almost always posterior.
Yes. Posterior dislocation is the most common type, typically caused by a fall on an outstretched hand causing hyperextension. Because of the significant force required to dislocate the stable elbow joint and the close proximity of neurovascular structures, there's a significant risk of associated injuries, especially to the ulnar nerve, which runs right behind the medial epicondyle in the cubital tunnel. Ulnar nerve injury leads to characteristic numbness in the little and ring fingers and weakness in the intrinsic hand muscles. Brachial artery injury is also a concern.
And we absolutely must revisit that unique pediatric mechanism of injury involving the proximal radio-ulnar joint, subluxation of the radial head, commonly known as nursemaid's elbow or pulled elbow.
Yeah.
Figure B 3.41.
Yes, this is purely a mechanical issue seen almost exclusively in young children, typically under the age of 5. At this age, the radial head is not yet fully developed. It's smaller relative to the neck, and the annular ligament that holds it against the ulna is relatively thinner and perhaps more lax than in adults.
So what happens?
If there's sudden, strong longitudinal traction on the child's extended and pronated forearm, the classic scenario is an adult suddenly pulling a child up by the hand or wrist to prevent a fall, or swinging them by the arms. This force can actually pull the small radial head distally, partially slipping it out from under the grasp of the annular ligament. The ligament might get trapped between the radial head and the capitulum.
Ouch. And the child presents?
The child typically presents holding the arm limply at their side, often slightly flexed and pronated, and refuses to use it due to acute pain, especially on attempted supination. The beauty of this injury, though, is that often a skilled clinician can easily reduce it with a specific maneuver, usually involving gentle supination of the forearm, combined with flexion of the elbow, popping the radial head back into place under the annular ligament, often with immediate relief of pain.
Simple mechanics causing it, simple mechanics fixing it.
Often, yes.
Okay, and finally, let's take a comparative look at wrist fractures related to figure B 3.42 to highlight that pediatric versus adult distinction one last time.
Right. In adults, the most common wrist fracture from a fall on an outstretched hand is typically a fracture of the distal radius itself, like the classic Cowles fracture with its dorsal displacement and dinner fork deformity.
But in children.
But in children, consistent with the pattern we saw at the medial clavicle and the medial epicondyle, the weakest link is again the growth plate, physis. So the same fall mechanism often results in a fracture separation of the distal radial epiphysis. The physis gives way before the bone fully fractures or the ligaments tear. The distal epiphysis often displaces, usually dorsally, similar to a Cowles fracture appearance.
And recognizing this is key for management and prognosis.
Absolutely. It needs to be reduced and aligned correctly, but the prognosis for future growth is generally good, provided the fracture doesn't crush the germinal cells of the growth plate itself. A Salter-Harris type V injury, which is rare. The bone's growth potential is usually preserved.
So, across the limb, the patterns of injury are dictated by this interplay between inherent stability, ligamentous strength, dynamic muscular control, and, crucially, the stage of skeletal maturity.
That's a perfect summary.
This has been a truly comprehensive, in-depth exploration of the joints of the upper limb. We have covered the full spectrum, moving from that singular bony anchor of the pectoral girdle at the SC joint through the dynamic trade-offs of mobility versus stability at the glenohumeral joint, the dedicated hinging stability of the elbow, the rotational brilliance of the radio-ulnar joints, and finally the intricate precision control provided by the wrist and hand articulations.
Yeah, we've really seen how the body manages this continuous balancing act. You have extreme freedom of movement at the shoulder, but that necessitates sophisticated dynamic muscular stabilization from the rotator cuff. Then you have the rigid stability provided by the elbow joint, which is absolutely essential to ensure that the hand can function effectively, demanding, as we saw, a stable, mildly extended wrist for maximal grip strength. Every structural detail sees to serve a higher functional purpose.
It's a marvelous sequence of increasing complexity and specialization, culminating in the functional brilliance of the hand, which itself rests upon all those proximal joints, those fixed and moving pivot points we've analyzed today.
Definitely. And maybe to leave you, our listeners, with a final provocative thought that connects back to some earlier anatomy, but has profound clinical implications related to these structures. Let's reconsider the deep fascia that invests the arm, and particularly the forearm.
Okay, the tough connective tissue sleeve around the muscles.
Exactly. Recall that this deep fascia, the antebrachial fascia in the forearm, is incredibly dense and relatively unyielding. It does not stretch easily. We might have mentioned its role in the musculovenous pump, helping push venous blood back towards the heart when muscles contract within it.
Right, the fascia acts like a tight stocking, aiding venous return. But what happens when that rigidity, that inability to stretch, turns against the body, particularly in the confined spaces of the forearm compartments?
Well, consider the implications of significant trauma, like a crush injury or a bad fracture, causing hemorrhage, bleeding, or severe edema, swelling within one of those compartments. The forearm contains these very dense, clearly defined fascial compartments, typically an anterior flexor, a posterior extensor, and sometimes a lateral one, all bound by this unyielding deep fascia and the interosseous membrane between the radius and ulna.
So if bleeding or swelling occurs inside one of these tight compartments,
The pressure inside that closed space starts to rise dramatically, simply because the fascia cannot expand to accommodate the increased volume.
and this dangerous rise in pressure is known clinically as compartment syndrome.
Precisely. And it's a true surgical emergency. If that intracompartmental pressure rises high enough to exceed the pressure within the capillary supplying the muscles and nerves inside.
Blood flow stops.
Exactly. Blood flow to the muscles and nerves contained within that compartment becomes compromised or completely cut off. Ischemia sets in very quickly. And within a matter of hours, if the pressure isn't relieved, the muscles and nerves can begin to suffer irreversible damage. They can actually die.
Leading to permanent functional loss.
Yes, potentially leading to permanent muscle death and fibrosis, resulting in a condition called Volkmann's ischemic contracture, where the hand and wrist can become permanently flexed and clawed, resulting in a devastating loss of hand function.
So that seemingly simple connective tissue sheath, the deep fascia, which normally helps function, suddenly becomes this critical, potentially limb-threatening constraint in the face of trauma. It demands rapid diagnosis and urgent treatment.
Usually involving emergency surgery, a fasciotomy where long incisions are made through the skin and deep into the fascia of the affected compartments to literally open them up and immediately relieve the dangerous pressure, restoring blood flow before permanent damage occurs.
It really forces us, as you said earlier, to think of anatomy not just as static structures on a page, but as dynamic mechanical systems, constantly interacting with design features that can sometimes, under specific pathological conditions, work against the body's own interests.
A crucial perspective for clinical practice.
Indeed. Well, in this deep dive, we have completed our study of the upper limb by examining the joints of the pectoral girdle, shoulder, elbow, forearm, wrist, and hand, bringing together structure, function, and clinical relevance.
And this actually concludes our series covering Part 1, the introduction and upper limb of Moore's clinically oriented anatomy. We hope you'll join us in our next series as we continue our regional exploration of the human body, likely moving on to the lower limb, or perhaps the back.
Thanks for listening to Bookfulness.